aneurysms. We know they're not great. CTA and MRA are not great for aneurysms less than 5 millimeters, and a third or more of those aneurysms are in that size. But what are we looking for with CTLP? Are we looking for aneurysms? No, we're looking for subarachnoid blood, and CTA and MRA were not designed for that. They're looking for the aneurysm. They're not better tests for what we're trying to do. And in this particular article, there was some referral bias. They included people who had the aneurysm. Now let's see how good CTA and MRA are. And you know, it's a little difficult to do that because you've already selected out patients with the disease. All right, the Scottish Medical Journal. Anyone here Scottish? Any men with kilts willing to stand up? But I think this is great, and I put this in here from 2009 just to tell you where the data is. And there were probably 5 or 6 articles published in 2009 to 2010 about using CTA. They compared it to digital subtraction angiography, saying once you've identified the subarachnoid hemorrhage, what's better, do the angiogram or just do CTA? They're saying CTA was better to map the brain, and it reduced delays by 64%. Angiography is going away. CTA will probably take its place. That's its role, not replacing CTLP to identify the initial subarachnoid hemorrhage. All right. And then the final piece of data here, which is very important, I think, is from Annals of Emergency Medicine 2008. This talks about the concept, is CTLP still worthwhile? Is it necessary? 592 patients, 61 with subarachnoid hemorrhage. Sensitivity of this combination was 100%. They found everybody. Specificity, 67%, so they still had a few false positives. The beautiful thing here is the negative likelihood ratio was 0. So if you had a negative CT and a negative LP, you will not have a missed subarachnoid hemorrhage. Those two tests in combination have an incredible negative predictive value, and it still will be the two tests we need to do to rule out subarachnoid hemorrhage.